Thank you very, very much for joining us today. This is a very short, high-level webinar to mark the release of Joint Care, the NCEPOD report looking at the quality of care provided to patients with JIA. So we're going to have a few speakers. We're going to hear from Gavin Cleary, who's going to tell us why the report was needed in the first place. You're then going to hear from Katie Malvern and Anthony Michalski, who are going to talk about the report findings. And then from Flora McCurlane, who's going to talk about the GIRF work that's coming up, which is a really exciting thing that's happened during the course of the project. So it brings it all together very nicely. So I'm going to hand over to Gavin.
Thanks, Marissa. Really just a huge welcome to everybody to this webinar to mark the launch of the NCEPOD inquiry into JIA, which, as Marissa said, is called Joint Care, a review of the quality of care provided to children and young adults with juvenile idiopathic arthritis. So really, why are we here? So despite undoubted advances in medicine technology, perhaps particularly the development and introduction of biologic medicines for the treatment of JIA, I think we all recognise that there remains a gap between the real world day-to-day outcomes for patients and young people with JIA compared to perhaps the ideal world of outcomes in clinical trials. Unfortunately, this historically is and almost certainly remains quite strongly associated with delays in access to specialist multidisciplinary care. So perhaps trying to understand this and make improvements in care without data is probably difficult at best and maybe actually impossible. So I think we can trace back the particular journey to where we are today to at least a decade or so ago, with the introduction of the BSPAR standards of care for children and young people with JIA. Subsequently, an audit against those the initial standards of care highlighted considerable variation in service delivery across the country, and this included variation in time to access specialist care. It became clear to us as a community that there was a lack and a need for quality indicators in JIA, and importantly, a need to develop patient-reported outcome and experience measures to help inform improvement programs. So with this in mind, a group from within the clinical community, a multidisciplinary group, worked with patients and carers to develop an audit tool which included novel patient-reported outcome and experience measures. And this audit tool was subsequently incorporated into a data set referred to as the Capture JIA data set. I think this process has helped us as a community think about how we use real-world data to help understand and drive improvements in care. And I think what we've seen over recent years is that we've come together as a community with patient partners, with charity partners, to develop a portfolio of real-world improvement methods for JIA. So many on the call will be familiar with the British Society of Rheumatology and GIRF funded Learning Collaborative, where clinical teams from across the UK came together and were coached in quality improvement methodology. This NCEPOD inquiry, which I think is one of the pivotal tools for driving quality improvement moving forward. And then finally, the GIRF program, which is now, we're really in the heart of an information gathering process using very specific GIRF methodologies. So when we came together as a clinical community with colleagues at NCEPOD, I think our goal was to shine a light on variations and inequity of service delivery across the country, to improve the visibility of JIA and associated inflammatory eye disease, uveitis, at a national level. We've been really sort of at the heart of everything we've done is to take an MDT approach, working alongside patients and families, charities and professional bodies as key stakeholders, to drive to develop a portfolio of improvement strategies using different but overlapping tried and tested methodologies, and really quite crucially, that this takes a life course approach. So I'm very excited now to hand over to Katie and Anthony, who are going to take us through some of the key findings from the report, and also to share, I think, some of the tools that will accompany it. Thank you.
So thank you very much, Gavin, for that very clear description about why the NCEPOD study was done. I'm going to be telling you how it was done, and then Katie will be telling you what we found. So it's important to realise that this wasn't an audit. We didn't select a number of specific patients and look at their care against BSPAR or other standards. It's qualitative research. It's a snapshot. And with the patient population, when patients diagnosed with JIA between the 1st of April 2019 and the 31st of March 2023, so it does span the COVID era, but there's patients from before COVID and after COVID as well. And these patients were diagnosed or experienced symptoms before their 16th birthday, so they fitted the description of and classification of JIA. Now, over that time, we identified 4,912 patients, from which we selected 376 for further study. We sent questionnaires to the clinicians looking after them, that's both the paediatricians and the GPs. We've got 290 sets of case notes returned. These were anonymised, and then they were reviewed by a team of independent reviewers that we appointed. We received 84% of the organisations to which we sent organisational questionnaires returned them. So that gave us 122 organisational questionnaires. What does the organisation think it's doing? And we had 130 primary care questionnaires. We did a survey of parents and carers, and we had 68 responses from that. And we did a survey of health professionals involved in JIA, and we had 117 responses from those. Now, these are big numbers, 4,900 patients. So the data that you're going to hear from Katie is a snapshot based on big numbers. So Katie, what did we find?
Thank you, Anthony. So I'm going to go through the sort of 5 main themes that came out of the report and recommendations from those themes. So the first one was about raising awareness of JIA and its symptoms with those who might see patients. So we really found that patients frequently sort of bounce between services before finally getting to rheumatology. And there seemed to be a general sort of lack of awareness of when patients should be referred. So certain healthcare providers not recognising that patients presenting with a set of symptoms required a referral to rheumatology. There seemed to be a lack of protocol use within primary care. So really knowing what GPs should be looking out for and when to refer. And there are lots of good resources out there which can be put in place to help this. We know that there's Think JIA and Versus Arthritis, which have some really good guidelines and protocols to follow to prevent this happening. Because ultimately, that delay in referral means delay in diagnosis and delay in treatment. The second recommendation that came out was about streamlining local referral pathways with clear timelines for patients with suspected JIA. And as Gavin mentioned, there's a huge amount of variation between how these patients are cared for. There's a variation in commissioning of these services. So some rheumatology services have specialist commissioning, some don't, and this leads to obviously inequity of care. The NHS England Specialist Services Dashboard indicates that patients should be seen within 10 weeks from symptoms to being seen by a rheumatologist. And yet you can see that only half of the patients within this study actually were seen within that timeframe. And as I said before, it's often because they're referred to the wrong service. So that was the most common reason for delay, that they were seen by orthopedics or went to the ED before they actually got that referral to rheumatology. The other thing that did come up quite frequently was that GPs were unclear when to refer patients and what tests to do before referrals. So they might do the investigations and then wait for those investigation results to come back and then refer. So another big delay in that patient getting the care that they really needed. The third theme and recommendation that has come out of this report is around medication. So many patients are treated with subcutaneous methotrexate, and there was been a delay in initiation of that treatment. Not only was there a delay, but sometimes patients were started on inappropriate treatments before finally getting that subcutaneous methotrexate. So put on oral methotrexate while waiting for training. So there's a real push to actually train patients and parents, whoever is giving the medication, at the time that the medication is prescribed and not have that lag time. And there are resources that can help with that. There's online training, there are videos to watch. There, we can have information leaflets on how to administer the medication. So we should be thinking of innovative ways to improve this. The fourth recommendation was around access to an MDT, so ensuring that there's ongoing access to physiotherapy, occupational therapy, pain and psychology services. So JIA is a chronic disease, and it happens during childhood and goes on to happen to have symptoms during adult life, and so it's so important that it's approached in a holistic way with a multidisciplinary team. And yet we found that actually only 34.5% of pediatric JIA units actually used a multidisciplinary team approach to care. And actually, as patients got older, that MDT approach seemed to get less. So I would argue that actually it should be totally the reverse, that there needs to be much more support as that young person gets older, and particularly going through transition to adult services. We also know that JIA is often diagnosed during adolescent years, and adolescents have an awful lot to cope with anyway, so the need for this additional support when they're having to navigate and negotiate having a new diagnosis is absolutely essential. And we saw that signposting to access peer support also decreased with age. Again, it's absolutely vital during certain times, particularly adolescent, that peer support is available. And then finally, the fifth human recommendation was around providing holistic, developmentally appropriate healthcare within rheumatology services. So only 43.5% of patients had advice and information to support holistic health. And we really found that the questions weren't being asked to adolescents. So there wasn't curiosity around their wider life and what else was going on in their lives that would influence their disease or would influence their engagement with rheumatology services. And things like, letters weren't being written to the patient when they were at an age where they should be receiving that communication directly to them. And as I said, there wasn't that sort of psychosocial history aspect, being taken. So using something like the HEADS tool to aid with psychosocial history taking. And recommendations to improve that would be things like considering co-production, so developing these services with adolescents, holding clinics out of school hours, so evening clinics, during weekend hours, having joint clinics with paediatric services and adult services. So that's really important, so that young person engages with adult services before moving to a very different type of care. And then use of apps and messaging services, which are really important when trying to engage adolescents with healthcare. And they would be great when, particularly with this kind of diagnosis, we can really support young people with JIA using other technologies. we also sort of took quotes from parents and carers of young people with JIA, which really illustrated the report. So a few of them here, I'm not going to read them all out, but the one that sort of stands out for me is understanding why it happens and the impact on mental health of children with it. And, and I don't think that's recognised enough, that we need to be approaching with that sort of holistic care, that MDT approach, and realising the impact on their wider life. So along with the report, we also have a number of tools that can be used to help services improve care. So if you go to the website, you'll see all these things that are listed. There is an audit tool, which is really helpful, again, for assessing services, driver diagram, fishbone diagram, and importantly, a commissioner's guide. So I do urge you to take a look at all those resources. Now, Flora, I'm going to hand over to you. Thank you very much.
Katie, thank you. That was absolutely brilliant. So I've been tasked with talking a little bit about what next. I mean, I guess I wanted to start by just flagging that this is our first ever national QI project in rheumatology, and particularly focused on JIA care. It's been amazing, and I guess the first part of my talk is to say thank you to the NCEPOD team, who've worked so well with our community, really listening to our worries around timeliness of care, accessibility of MDT care, and really working with us to try and understand what's happening, perhaps also happening in places that we aren't, so to our patients before we get to see them. The recommendations are absolutely fantastic. The report itself, which you won't have had time to look at yet, is comprehensive and actually illuminating. It really details the patient journey, both from first presentation to GP, right the way through to transfer and establishment in adult services. So the purpose of the recommendations is really to help us as a clinical team, and you guys as patient partners, etc., improve pathways and experiences of care. So what we do with this is very much up to us as a community, I think. So if we move on to the next slide, let's just have a little think about a couple of the findings. I mean, look at this. This is just so helpful to finally have the data to support our collective concerns relating to delays in access to definitive care. So thank you. These data will really help us to build on work that's already happened. So Helen Foster and Tim Rapley did this work 10, 15 years ago. Nothing has changed, has it? We're finding exactly the same thing. We really need to think harder about factors contributing to delayed referrals into our services, and we need to think about how we work with our colleagues in acute areas and in primary care to mitigate these delays. The NCEPOD team, as I've mentioned, have already begun work on some tools to support us, some Think JIA tools for the primary care setting. And I guess our task is to think hard about how we work better with primary care and acute teams, maybe rapid access advice lines, maybe clear advice and guidance pathways. Just this is a really, really important area for us to think about. Again, so important. Healthcare inequalities. Let's have a think about this. So the NCEPOD report absolutely supports our emerging GIRF data. Patients and families are really struggling. They're struggling with distance travelled for care, with cost of transport, with time off work, and they impact significantly on timely access to care for children. Again, this matters so much. So what can we do as clinical teams around this area? I would say, first of all, have a think in your own trust. Talk to your management teams. What's your trust doing to support families from the point of referral onwards? In fact, some trusts are doing a huge amount. So what can you learn from other trusts? Alderhay, Sheffield Children's, Birmingham Children's have been leading some fantastic interventions in this area. And actually, Gavin and I are really lucky. We've got involved in quite an exciting NHS England project developing a new patient-centred children's prioritisation tool. So there are things happening in this area. It's going to be about collaborating and listening to each other, I think. Developmentally appropriate healthcare, again, it's just absolutely fantastic to have this window into care up until the 20s, because obviously as paediatric teams, it's often difficult for us to understand what's happening after that point of transfer into adult services. The NCEPOD report is very helpful. It further evidences the real challenges associated with the provision of developmentally appropriate healthcare, both in the paediatric environment and in adult settings. The NHS is simply an organisation that was not designed to support young people with long-term conditions, and we have to understand this and work with it better. We need, as paediatricians, to absolutely acknowledge the huge challenges faced by our adult colleagues who try so hard to deliver developmentally appropriate healthcare in the context of little or no funding and often minimal access to that vital MDT support. So the question is, how can we work better with this age group? It's all about collaboration again, isn't it? As Katie said, think about co-production to identify solutions that could work for your cohort of patients locally, and also use the amazing support that's on offer from our patient organisation partners. I'm sure some of you guys are here today. There's a whole load of stuff out there already that we should be engaging with better as clinical teams. I guess our tasks, first of all, are to review the report in detail. Honestly, it's brilliant. It's a really, really good read. So that's the first thing to do. And the second is to have a think about those joint care QI tools. I'm sure many of you will have already engaged with the transitional care, the adolescent care NCEPOD report and the audit tools. They're really, really useful, and they make a big difference to understanding how your particular service is working. Contextualize what we're hearing here with your GIRFT observation visit and your GIRFT observation notes. There's so much overlap, and the two are going to work really, really well together. And then finally, it's all about collaboration. We've got so many opportunities to work together to improve care. We can innovate with primary care, with acute services, general peds, adult care, patient organisations. It feels like a massively pivotal moment to me in JIA care. So I suppose I was just going to finish by saying it's brilliant that you're here. Make sure you stay part of this.